Welcome, everyone, to this session at ISS. This is implementation of the Functional Mobility Assessment in Brazil, a pilot project. I'm Nancy Augustine, and I will be moderating today's session. I'll provide you the CEU code at the end. Before we get started, please remember to mute yourself. You can ask questions using the chat feature. We will hold your questions to the last 10 minutes or so of our session today. And now I'll go ahead and turn it over to Anna Allegretti, your presenter for the session.
Thank you, Nancy. Hello, everybody. It's a pleasure to be here today. ISS is, it was always very close to my heart. When I moved to the United States, my first professional presentation was in ISS in Vancouver. So every time in ISS, I will never forget that experience for sure. So today I am going to talk about a topic that it is very close to my heart, is the implementation of the functional mobility assessment in Brazil, and is a pilot project. So hold on, I'm not being able to change my screen. I don't know why. Okay, here it is. So for the learning objectives, I am going to describe the need of using outcome measures in Brazil, describe the importance of the cultural adaptation of the UDS, that is an assessment used with the FMA. It's a form, it's not an assessment, it's a form. Describe the implementation phases of this FMA and UDS in Brazil, and learn what are the barriers and facilitators that we have been facing in doing this implementation process. Why Brazil? So if you realize right now I have a very heavy accent, I am a Brazilian. I graduated from my occupational therapy school in Brazil. And in 2002, I went to the University of Pittsburgh and got my master's degree and my PhD degree in rehab science and technology. I was part of the data collection from the FMA. So when Dr. Schmiller and Dr. Margot Holm and Dr. Tamara Mills, they were developing the FMA, I was a student in the project. So I know about the FMA. So if you think there would be a bias of using the FMA as an outcome, and starting this project in Brazil, that's where I'm familiar with the tool, and I think it's a user-friendly. So I also have very good connections in Brazil. I have a work connection in Brazil. I have friendships established through my work in Brazil. So it was a perfect country to start this project. And the idea is that this implementation of an outcome measure, that I would be helping other countries in Latin America as part of a RESNA project, that I'm going to talk a little bit about it too. Another important factor that led me to use the FMA in Brazil, it was that a group of researchers had been already translated and culture validated the tool into the Brazilian Portuguese. So I want to make a distinction that the FMA has been translated into Portuguese, but into the context in Brazil. So not in Portugal, not other countries of the world, they speak this Portuguese. There's nuances of the Portuguese like the Spanish. So this tool, the FMA, has been validated and translated to the Brazilian Portuguese, if you would say that. So just talking a little bit about the FMA, it is an assessment that was developed at the University of Pittsburgh and measures levels of satisfaction of mobility device users in regards to the performance of 10 daily living tasks while using the device. So the FMA consists of 10 items carrying out, and the 10 items are carrying out of my daily routines, comfort needs, health needs, operate with independence and safety, reaching and carrying out tasks at different surface heights, transfer from one surface to another, personal care tasks, indoor mobility, outdoor mobility, and personal and public transportation. It also is scored on a 7-point Likert scale, in which you have 6 as completely agree and 0 does not apply to me. So those 10 questions, you have this scale to answer, and if the question does not apply to you, just say, just give a score of 0, that does not apply. Like the advantage of using the FMA is that it's easy to use, does not take a lot of time to complete, it's about 15 minutes. It can be administered over the phone. The FMA assesses mobility to the entire range of mobility devices, such as wheelchair, crutches, walkers, canes, scooters, and prosthetic limbs. One of the disadvantages that I have to point it out that it's like in order for a clinician or anybody that is interested in using the FMA, you need to ask permission. So in the end of this presentation, I have my email. Dr. Mark Schmiller is also a person that can explain more about the permission process. But if you have interest in using the FMA, you can email me and I will direct you to the right channels of getting a permission to use the tool. So it's not that it's like, just easy to access from the internet. You need a permission to use the FMA. I am going to talk about some, like the papers and like the process in Brazil. So like I have the ISS in the DOI here if you ever find the original paper for the FMA. So as I said, like, this project is about, it started as a RESNA initiative. And as a RESNA initiative, this project was, RESNA has a branch that's called International SIG. And within the International SIG, there are a couple of tasks that we plan to complete. One of the tasks, one of the arms of the International SIG was the outcomes in implementation of outcomes in Latin America. And that actually started with many conversations that I had over the years with the clinicians, also with wheelchair manufacturers and suppliers. Because when we are providing equipment, we want to know if what we are providing is meeting the client's needs. So we need to collect data and see if we are doing a good job. So if you were in the presentation this morning, that Mary Shea and Jessica, they were talking about the service delivery process. The RESNA is actually reviewing this whole document, and they talk about the 8 phases of implementation of the service delivery process. So throughout these 8 phases, like they said, it's important to collect outcomes, right? But then once the process is over and you deliver the equipment to the client, do you want to know as a clinician if the service provided was adequate? So in Brazil, there is a need for standardized measurements. And so that's why like Daniel and his group translated and validated and made the cultural adaptations of the FMA, because there was a need for us to have an assessment available to Brazilians to collect this data. So it's really important to understand and, what are we doing and is it being effective by collecting data in a systematic way? So the use of a standardized assessment, it's really important. So use of the assessment like the FMA that has been validated, translated, and culturally adapted to Brazil, it's a key, right? So that's how we began the story of thinking about this process and implementing how are we gonna help clinicians in other countries that are not part of their culture. It's not part of like the Brazilian culture that we collect data systematically, because the funding process in Brazil is different than the United States. So there's not a lot of culture there, like of clinicians collecting data in a very systematic and standardized way. So with this initiative, that was one of the goals is to capacitate, to help clinicians in understanding the importance, but also how they're going to incorporate that process into their clinical practice and really change their clinical practice. So yes, I am from Brazil, but I have been living in the United States for the past 20 years. So in order for us to implement a project, I think it's really important for us to consider the clinicians that live in that country, the stakeholders that are living in that country, because there is we need to understand the culture, the healthcare system model, what are barriers they would be facing that because we don't live there, we don't understand. So I invited 8 group 8 clinicians that I know them, and I know because of previous conversations that they were interested in being part of this group and in being invested in the process of this implementation. So I invited them, and they were clinicians from different areas. So like we had OTs and PTs that were professors in universities or academia, OTs and PTs that were working in private settings, others work in public settings, and we have wheelchair vendors included. At this moment of implementation, right, the wheelchair user comes as when we go to the phase of the implementation, they are testing the protocol, but as just like how we're going to implement this, then we did not include at that point wheelchair users or consumers for that matter. So we are a group of, if you say counting me, we're a group of 9 clinicians that are working in this project in Brazil. So we worked through phases of this implementation process. So because the FMA already had been translated and validated and culture adapted to Brazil, we didn't have to do anything with the FMA. But as part of the FMA use, there was a form called the Universal Data Set. That's the UDS. And the UDS is in English. So when we contact Dr. Schmiller, we ask for permission if we could also translate that universal data set, because the universal data set is a form that collects mainly demographic data. And I'm going to talk more about that, but would be nice to have, the combo like we use in the US. So the implementation phase, where first we would like to translate and make a cultural adaptation of the UDS. Then we would establish the protocol, test the protocol, and refine the protocol. So what I call protocol, it really is the whole part of this implementation, this process of using, implementing the FMA in the UDS, how we would make the clinicians would like to incorporate that in their clinical practice. And the group, we meet regularly via Zoom. So during COVID, when we started this project, it was right when COVID hit. It was actually a perfect project during COVID because we could meet Zoom. Clinicians weren't that busy because they couldn't see the patients. So it was actually like a perfect project. So if you would say, I'll talk about this, but if you would say that during COVID, it was actually a perfect timing to launch this project, and we have all had a lot of time to work on it. So it was very gratifying, I think, during the COVID. So like I said, like the FMA has been translated and validated, and in conjunction, we want to use the UDS. And just to make it very clear, the UDS is not an assessment tool. So it is a demographic form. So in order to validate and make a cultural adaptation of an assessment tool, there is a long process. You have like to translate back translation again. And so it's a very detailed and process that was done with the FMA. So because the UDS is a demographic form and not an assessment tool, we didn't have to do all the process that an assessment tool has, that you have to go through when you are translating an assessment tool per se. But what we did with the UDS is that we translated the UDS, and then we had to look at the translation and see, okay, what in this form applies to the Brazilian country, cultural, and what does not. So then we modify a couple questions of the demographic form to meet the Brazilian's needs, the Brazilian need. Talking about the UDS, there are 2 forms of the UDS. They have a UDS form that is used in the initial intake, and then they have a UDS form that is used for follow-up. So the questions are a little bit different between the intake and the follow-up. We thought the use of the UDS would be very important, again, to systematically collect this demographic data so we could compare across countries, especially when we are talking the bigger project like RESNA, the Latin America. So that would be nice to know, okay, patient's diagnosis, how old is the patient? What current wheelchair they have? After the evaluation, when we do the follow-up, what wheelchair they was prescribed to them. So if we would think of a client with spinal cord injury C7 that came to your clinic with a manual wheelchair, after your evaluation, so then all the reasons that were detailed in the UDS, we prescribe a power wheelchair, but then this in the same, in the same spinal cord injury C7, oh no, for this other client, we didn't do a power wheelchair, we did a manual wheelchair with power assist or a manual wheelchair. So we would have, like the same type of data just to see what in this demographic form you can collect that type of data. So I thought that's why one of the things that we really think the UDS in combination of the FMA provides lots of good data. So we can see, okay, in this service delivery model, in the service delivery process, what were the factors or not that may have, helped one guide the prescription for a manual or power or some. So there's a lot of things that we can do when we have a universal way of collecting data. So that's why the Brazilian group, when I presented that, they were like, okay, sure, well, let's then translate and validate, culturally validate the UDS. So the translation of the UDS was performed by a Brazilian that is fluent in English. And then this translation was presented to the group. And when we translate, there's some wording or grammar that doesn't really necessarily looks very good. And so there was a lot of back and forth refining this translation version. Let's say that, let's not use this term, let's use this other term that is more appropriate, that is easier for clinicians to understand. Because another thing that I think we have to be sure when we are, having like a demographic form, or is that we that are in this field of sitting in mobility, wheelchair mobility, to us, some of these terms or some of these questions are very clear. But if you think about a novice clinician that would be getting this form, they also have to be able to understand what the questions are, what we are asking. So that was a lot of our thought process in how we're going to make or how we can adapt this UDS information to, across everybody. So in addition to the translation, we did a cultural adaptation that was needed so then we could use, this information in Brazil, but also wouldn't be so different that we could not compare if we would be in the United States. So for example, in the UDS, in the American version of the UDS, there is a question about, the HIP codes, like what is the wheelchair code? So if it is like a K005 or a power wheelchair group 1, 2, 3, 4, so like you could do that. But other countries don't have that system. And when we talk about this, it doesn't make any sense to them. So we went back and forth with this question, and how could we then create a question that would capture? So if we say a K005, if we work in the United States, we know what a K005, what are the characteristics, what are the parameters a K005 wheelchair has to meet. But in Brazil, that doesn't mean anything. So what we created was a list of wheelchair features and characteristics. So, like it is a question where you can check if you have a cross frame or rigid frame, or if you have, wheel camber, or if, so like there was like a list of characteristics of this. And we had one for manual wheelchair. So if the patient uses manual wheelchair, yes, then click the features or the characteristics or what do you have in the wheelchair? And if you have a power wheelchair, click here, and then what do you have in a power wheelchair? So one of the things that that when we were doing this cultural adaptation in Brazil, also it is that Brazil has two scenarios. You can have a private buyer, and you can have the public system. In the private system, the wheelchair user, their family is responsible to purchase the equipment. equipment. So they have, if they have means, they will purchase. Now, if they don't have, they go to the public system. And then in the public system, you have a limited type of wheelchairs that you can get from. So we are working. So one of the goals of collecting this data too, in the private and the public sectors, it's also that, okay, this data, we believe that will give us good information to go back to the healthcare system and say, look, you as a public system are just providing these wheelchairs, and we can imagine what wheelchairs we're talking about. The wheelchairs that may not have the best frames, or the power wheelchair doesn't have all the power wheelchair features. So we want to go back there and say, when we compare private and public, and when we compare satisfaction, when we compare, when we are using the UDS, and there's one question: do you currently have pressure ulcer, pressure injury? Let's see if the equipment that was provided it's part of this in the place. So we want to use one of the goals that we want to use is standardized assessment to collect this outcome data, to collect patient satisfaction. It is then to go back to the system. How can we make this better as a country? So we have an overarching goal that is much bigger than just collecting FMA data, right? We believe, we know, it is known that if you have data that has been systematically collected using a standardized assessment, we can make cases. And so we can advocate for better service, for better equipment. Another question that another example about a question that we actually had to remove is, we don't have ATPs in Brazil. We have Brazilians that have taken the ATP. So like I'm one of them, but there's other Brazilians that have the ATP, but as a culture, you don't have to have an ATP or be an ATP to provide the more complex rehab equipment. So so the level of capacity, like education, we also don't know. So we kind of had to remove the ATP question there and ask, what is your specialty? We have a couple options, and then there's others too. So like it could be PT, OT, or wheelchair vendor, So that was another, there are a couple other questions that we had to do that. Just some examples of the questions that we had to do that. And I also work with a group in Colombia, and we are also doing this process in Colombia. So it's very interesting too, to see, we are in Colombia again, we don't have the same HIP codes, we don't have ATPs, but also there were other questions that they were like, we can't ask a question like that. So let's, even like the Brazilian and the Colombia version, it's very different too. So, and then once the translation and the cultural adaptation were concluded, then the group discussed as a need to create a guideline. So, okay, we have the UDS, we have the FMA. How are we going to use that? In the US, for the use of the FMA, the FMA is an assessment that is self-explanatory. You have 10 questions, you read the questions to the patient, and they have the scale to answer. And you do the FMA in the initial evaluation, the FMA in the UDS intake at the initial evaluation. Then you have the delivery day, I'm sorry, you don't do the UDS, but then the FMA and the UDS, you do a follow-up assessment at 21 days, 90 days, 180, and 365. I consult Dr. Schmiller about how they use this. And it's kind of, okay, it's known, and there's not a lot of instructions in how to use the FMA, how to read the questions, maybe because it's part of the American culture already to use these outcomes. But in Brazil, we felt the need that we had to develop a written guideline. So to teach clinicians in how to use this assessment, So in order for in order for us to do that, we said, okay, if we are thinking bigger picture, that we want to compare this data at some point, let's follow the same guideline that the US has. So we're going to have the FMA and UDS intake as an initial evaluation. So that means that clinicians in Brazil that are doing wheelchair assessment, that are part of this group, added that portion on their clinical practice. And then as a clinical practice in Brazil, you deliver the chair, and unless the patient has a concern, or, it depends on the clinician, really, they can say, okay, I'll see you in 3 months, I'll see you. There's not a lot of standardized way of, I'll see you soon, like the follow-up. And, in some areas of Brazil, it's believed that if, okay, you deliver your wheelchair, I have nothing to do with this anymore. And that's not the case, right? When we deliver the wheelchair, we never say goodbye. We say, see you soon. Hopefully that is see you soon, bring good news. But sometimes, most of the times, a lot of the times, we need to do modifications, adjustments. So it was very important that we wrote that in the manuscript. We, as part of this process, and when we talked about the implementation of an outcome measure, we cannot forget that in some countries, the service delivery process, we don't have the 8 steps that are proposed by as best practice. So while we are doing this guideline, we are also talking about this process, the 8 steps of service delivery. We are also talking about what best practice is. So there was a lot of things that are coming into place. And so it's not only about, well, let's use this clinical, outcome measures, but okay, where, when to use, and the FMA is one of the assessments that can be used. But if you want to measure, when you deliver, if your consumer, your wheelchair users has the appropriate skills, then you don't use the outcome, the FMA at the moment. You can use the wheelchair skills training, because you really want to evaluate the skills. So there are other assessment tools that has also been validated and translated to Portuguese. And so that's the outcome implementation name from RESNA. It's broad. I started with FMA, as I said, just because I'm more familiar, and to me it was just an easier process. But I want to leave it very clear as a disclosure that is that not the only tool that is translated and validated into Portuguese, into Brazilian Portuguese. There are many groups using tools, and we actually, because of this project, our group actually did another side project that was, what are all the assessment tools that are related to assistive technology, including with mobility, that has been validated and translated into Portuguese, into Brazil. And we also compile a document. And we're gonna disseminate this document into universities, to clinics, to everybody, so they can have access and know, okay, all these assessments related to assistive technology have been translated into Portuguese and validated. So I would just want to make sure that, as today I'm presenting about the FMA, there's a lot of pieces and parts and other assessments that we have been looking into. So when we wrote our protocol and how we're going to use the FMA and the UDS, we then invited a wheelchair user to come and say, okay, well, let's test now. Let's see now how we are doing our assessment and incorporating the use of FMA and UDS. So one of the clinicians in our group had a patient that she was ready to do an initial assessment. And she was like, I'll talk to him. He's willing to be our volunteer and see how this process works. So because we thought that would be hard to all of us be in a Zoom watching her to do the assessment, and also HIPAA and like patient's privacy and protection, we then record the session with his permission, and we will watch it after the fact. So she did all the assessment as a group. Then she sent the link. We all watched the session, and we were able then to provide feedback. And like, was this the best time to ask the question? on the FMA questions, that it has been translated and validated. Was it easier if we had to show the schedule from him and then he would answer instead of us just saying, you have like 6 is completely satisfied and 0 does not apply? Would it be nice to have printed a paper? So there was a lot of brainstorming discussion that we were doing after we were watching this session in terms of us developing that guideline to be provided to clinicians. So we are putting a lot of effort, and we are still kind of being in the process of finalizing that document. So it was very interesting that all of us, that's part of the group, watched the video because, like the clinicians that are working on the sales part, like the vendors part, have a perspective of that. And then the clinicians that work in public and in private also had different opinions about it. So we refine the protocol, this guideline that we eventually will provide the clinicians that wanted to use the FMA. So again, like it's a refining, like I said, through this whole process, it was never the intent, or we never felt the need that the FMA version, the Portuguese version of the FMA needed to be changed, because that process of translating and validating that tool, it was totally different. There had many more steps, was much more, like robust and detailed in terms of translation and validation that we were trying to do with the UDS. The incorporating of this guideline because we want the 8 clinicians that are part of this task force all have the permission to use the FMA. So, and they all have access to patients in their working clinics. So what we think is close to the final version of the FMA, the guideline, it's there, and we distribute it to them. The idea was that at this point I would have like a lot of data to show, or some data to show. And due to COVID, there is like patients are not coming, or they are not allowed to go into clinic, and then Omicron hit. So like we are kind of all over. But we do have these 8 clinicians do have access to this guideline, and they have been highly encouraged to start using it. And then we're going to meet and say, okay, what part of this process do we want to improve? What part of this process, when you are there in the clinic with this guideline, that make it harder? Like another thing that we think about it as this follow-up, as like maybe the first one we do over the phone, or maybe the first one we tell them to come back, or because some of them live so far they can't come back. So like, do we say anything like that, or we just do over the phone? And if we identify an issue, then we invite them to come to the clinic to see what the issue is and how we can address the issue. So that's why like the guideline, the wording of the guideline is ready, but the use of the guideline and how to implement that in the clinic, we are still in the process of that. So, like it's a barrier in Brazil that the intention of this guideline, we are creating one. We want to have one document that would be used to private and public practice. And that may be a challenge because as we said, like there are differences. There are also differences in the public practice sometimes. In the public, because Brazil is a big country, and states and cities and municipalities have different ways of performing this service, of having a model for service delivery provision model. They don't have that. So we are hoping that with this initiative, we will see this difference, and hopefully we will identify in a systematic way that there is a need for a basic training. If you want to provide wheelchairs, if you want to work on the seating provision, you need to have a minimal level of understanding of the process, a minimal level of understanding of what equipments are out there in Brazil. the discrepancy between like you have people that have a lot of money and people that don't have a lot of money, people that have they have a good socioeconomic status, they can buy wheelchairs that are like Permobiles and Quickies and Invacare. They have access to that because we have places in Brazil where we have access to this wheelchair. It's not to everybody. So there's a disparity and inequality of having access to product that is really big in Brazil. I don't have the intention to minimize that, because I think it's a much bigger problem. But the clinicians that are providing, you should have the knowledge of what's out there, and then fight for it. Let's see if long-term we can change policy. Let's see if it's collecting this data in a systematic way, we can impact how this has been provided. So another barrier that we don't have, like as I said, the part of the implementation and see if this guideline it's really finalized and ready to go is the COVID. So we don't have a lot of access to patients right now. The FMA and UDS, for the clinicians to be able to use this assessment, they need to ask for permission. Again, my email is going to be listed in the end. You just have to ask for permission. And I think through RESNA, through the international SIG, through the outcome implementation in Latin America, I haven't faced an issue. So I have clinicians from Colombia, I have clinicians from Mexico, I have clinicians from Argentina, there are clinicians from Brazil that have access to the FMA. One thing that we ask them if they are part of this is that they are not allowed to just give the FMA copies. If they have colleagues or other people that want to use the FMA, then they have to ask for permission. And it's true in the United States too. You have to ask for permission to use the FMA and UDS. Like in this process, one of the things that it's a pleasure, and I want to thank you, the group that has been working with me in this project, because they are all motivated. We all have full-time jobs, and this is what we take as like a volunteer. So that's what I said. It was like a perfect time for COVID because we couldn't do lots of our clinical or of our clinical research. So we had time. So we were meeting every other week in the beginning, like really working very hard to launch this. And it was nice to start with the Brazilian group, because the language, I didn't have a language barrier there, and I understand the culture, and there was, I know these clinicians that are involved in this, but then also, okay, taking what I am learning with this group in Brazil and making myself available to other countries like Colombia, Argentina, Mexico, and I'm saying these countries because when I was at the University of Pittsburgh, I made friends with people from this country, so it's easier to reach to them. But if you are watching this presentation and if you want to be part, if you want to ask for my help in how to start the process of using an outcome measure in your country, please feel free to do so. I'm happy to help. By no means I'm calling myself like I'm an expert. I'm learning as I'm going in the process. I think there's a lot of people, there's a huge movement in this, in the wheeled mobility industry about outcome measures. We all see the need. And so the more people get involved into this process, I think the better it is. We want to know what's going on in other countries. We want to know what's happening. We want to know if we can help you with our expertise, with just being involved in so many projects, being part of so many other groups. If I don't know how to help, I can find people to help. So I think network, it's a very nice way. So I'm putting myself out there. So if you need any help, I'm happy to help you. I truly believe that if we are improving the service delivery process and using standardized measures throughout those 8 phases of service delivery, we will provide will be better in providing equipment that will meet our clients' needs, empowering them to do the tasks that they want to do. And so it's, you know, like a couple lessons learned. If you think it's easy, it's not. It has been 2 years, so probably by the time that I am like, I don't know, probably it's going to be implementing this whole in Brazil. I maybe have white hair. That's why I have this lady there. I don't know, but it has been a very nice process. It has been 2 years, and again, you know, with everything that happened, we haven't with the implementation, the per se, like embracing this in the clinical practice has been a little challenge. So another thing that we need to understand and then learn how to help these countries, or even in our own, or even in the United States, but understand the culture, understand the healthcare system, understand what service delivery process is, if they have so in many countries. You know, like sometimes I feel a little like disheartened when I hear, oh no, I went to the wheelchair store, and this is, I hear this a lot of, you know, when I'm talking to clinicians in Brazil, oh no, my client came to me, but the way that he got the wheelchair is he went to the wheelchair store, because there's a wheelchair stores in Brazil, you can go, and the person behind the counter, I don't know if the person was a clinician or maybe it was just a vendor, told me to buy this wheelchair. Well, I wonder why this wheelchair does not meet your needs. You know, there was not an evaluation process, there was not a trial part, there was nothing like not an intake, a formal intake. There was, so there is the service delivery is broken, right? So understanding that also you cannot disconnect the things. And I think like part of our job, it is to then educate. It is then is to help them, is to provide them resources. And look, people have been studying this a long time, and the World Health Organization, and you know, they develop 8 phases, and they are to be used in the countries. I mean, in, you know, less resourceful countries and everything. So let's look at this document. Let's study this document. Let's see how we can make this process better. So a way of collecting outcome data, and then what do you do with this data? So you're just going to collect, and what else? So, you know, like another thing that we all have to think about it, and I know that there's a group talking about this, like this big data, big databases where we can enter this data, input this data, and then let's see what's happening with these countries. I know that this has been in the talks for a while. I know there's a lot of people investing a lot of time in how can we do that, right? Yes, we may face many barriers, but we have to think about, okay, we are collecting this data, but what to do with this data? Like, again, you know, like the group in Brazil, well, let's collect this data because we want to change policy. We want to change how the public sector has been working in providing this equipment. We want to change things. And, you know, again, collecting outcome data, you can compare. You can compare regions in your country, you can compare cities in your country, you can compare your country to other countries. And so I think it's just like a win-win, you know, of acquiring this skill of collecting data and what to do with this data, how important it is to have data. I put some of the resources here. So RESNA, if you go to resna.org, there is a tab in RESNA that you can have access to a lot of position papers. And so like if you watch the lecture of Mary Shane in I forgot her name right now, Jessica Peterson. If you watch her lecture, so they are talking about the service provision position paper, and that's how that's going to be, you know, they are revising, so that's how this is going to be posted soon to RESNA. And so like these position papers, you can find a version in English and in Spanish. We were on the works with some of these position papers being translated in other languages. The ISWP, the International Society of Wheelchair Professionals, is another website that has many resources if you want to look in resources, service provision, And also the ISS, because this conference is going to be there for a year. So if you are choosing some lectures and missing others, you can go back and watch the other lectures. So, there are many resources out there. There are published papers that talk about the importance of using outcome measures in the service delivery process. So it's just a few resources if you want to start looking, so then you don't feel so overwhelmed. But I'm, again, happy to help in any way I can. This is my email, and I hope you thought it was helpful, like that I'm sharing this process with you. And again, if you are from a country that you wanna start a process, I'm happy to help or to connect with somebody that can help you more. So thank you so much. I left this time 15 minutes to the presentation, because if we can talk about it, we can ask questions. The questions are going to be put in the chat, and then Nancy is going to read them to me, and I'm happy to answer them now.
Sure. And before we get started, let me give everyone the CEU code for this session. It's C47CCC. And I'll also type it in the chat window. And Ariba will help with the questions. Thanks.
Yeah, so there were just a few questions in the chat. The first one is from Patricia. She said, that would be an interesting document to share here, the list of outcome measures that have been translated and are being used found useful.
Yes, Patricia. So I have this document like for in Brazil, but this is one of the things that we are talking to Resna, and Eleni she's the chair of the International SIG, and we want to do that. Is one task that we want to do, because, for example, and it was so funny because there is a version of the FMA that has been translated into I don't know if it was Italian or someone, and I told him it was to French, and I told Mark, I said, do you know that there's FMA? And he's like, oh no, I don't know. So when we start searching and we see that some other people already translated some of these tools, but that we want to make sure that there is a process to it. So we are working on this process. We were working this project. Hopefully we will have this document posted soon in the Resna website, but in the Brazil, I'm happy to share with the Portuguese, the Brazilian one, so everybody can see how it looks like. I'll share as a resource for my presentation for sure. I'm also going to share my PowerPoint if,
Great. And the next question is from Nancy. It says, you mentioned collecting FMA and UDS at 4 follow-up points, 21, 90, 180, and 365 days. What happens if the clinician doesn't see the client that often on the return visit? Is data collection at 1 follow-up sufficient?
Yeah, so one of the things of using the FMA and UDS that you can do over the phone, right? So this is a suggested follow-up. So one of the things that that when we were talking, okay, why 21 days? And so when the client gets the wheelchair, it takes a period of time for them to acclimate to the new equipment. So if purposely wait a couple days, couple weeks to ask them a question, is this working for you? If it's not, how what is not working? So that's why we waited the 21 days to the first follow-up. So when we established this guideline and we called Mark said that this is the ideal, but he's going to present the data this afternoon, right after me. I think at 3 o'clock he has a presentation. So I think it is an important question to ask. Now that he has been doing this for so long, what are the data points like that in the follow-up that you really see? Do you call everybody and they all answer the phone, even like 180 days post? Do you have that data? I think it's something that we can ask him, but this is the suggested follow-up.
Okay, and the last question is just asking if you could share your email once more.
Oh, sure. I put in here in the chat.
And And while you're doing that, there are several compliments on your presentation, and appreciate your global perspective. And just thank you for the work in the area. So we really do appreciate your expertise and your time today.
Oh, thank you so much. It's my pleasure. Okay, if you know, I don't know, if you don't have any more questions, then you have a little bit more time to go to the other session. I really hope, if you can, that you join me at 6 o'clock. We're gonna have like a conversation, an informal conversation, and it is what's called a happy hour, I think is. I don't know. I'm gonna be drinking water, but you're more welcome to drink water for a happy hour. But I do wanna hear, like, one of the questions that I wanna pose. First, I think having a virtual conference, I miss everybody, but I do think that gives opportunities to a lot of people that could not be in person for many, many reasons to get the knowledge. And if you have any ideas, or if you have projects in Latin America or other areas of the world that we could brainstorm something. So please come and join me on my happy hour at 6 o'clock.
Thank you.
Thank you.
Thanks, everyone.
Thank you. Bye.